65-year-old woman comes to the emergency department due to nausea, vomiting, and abdominal pain that began 6 hours ago. She has also had a vague pelvic pain over the last few months, but says her pain never been this severe. So it's not an acute pain, it's chronic. Slowly started, now it's progressing. Fever. Physical exam shows a moderately distended abdomen. There's a tender bulging below the inguinal ligament. So that says it's a femoral part. Okay, you are not dealing with the abdomen. Lateral to pubic tubercle, that's most likely a femoral hernia. Okay, so this patient has a femoral hernia, but the question is, the overlying skin is erythematous. Okay, which of the following structure is most likely immediately lateral to the bulge? They're asking what is laterally next to the mass. It should be femoral vein, folks. Okay, straight. That's the structure most laterally. Look at this picture. If this is a mass, that's a lateral. Is that clear, folks? I was told in the real exam what they asked, what's most immediately medial, that's pubic tubercle. So you have to be careful with that, okay? So they could ask you both ways. Here they are saying lateral to the pubicle, but sometimes they could ask you both ways. So that's femoral vein. Is that clear, folks? Now, the previous question, you see, I know you could answer the question with the age also, elderly person, but I wanted to make sure that we don't just stick to that age. Sometimes they throw a question at the 40s and 50s, it gets confused, right? So even though you could use an age as factor, but we want the whole big picture to make sure we have enough evidence to pick it. All right, so that's about hernias. Is everybody clear, folks? All right, so now we are moving into physiology. GI physiology is the easiest one, only 2 pages, physiology done, okay? So this page, go to this page. So that's a good amount of anatomy we covered, and I hope that we made a difference in understanding. Abby, I hope I made you like anatomy now. Oh, okay. All right. So here, GI hormones. These are the best example of exocrine. Remember when we studied endocrine, we said the definition of exocrine, when you secrete a hormone that goes into the blood is endocrine. If it doesn't go into the blood, that's exocrine, right? Okay. Now, I know when you look at this page, you guys are overwhelmed. There's so much information they added here. It's a summary page. What we need to learn, we need to know the name of the hormone, where it comes from, and what's their function. That's the main part we need to learn, and possibly some regulation. This notes, ignore it, because they're adding pathology and everything as a summary. By the time we finish GI, you would know more than that. Now let's go with this, folks. First one, gastrin. Gastrin is a hormone produced from the G cell of the antrum. So G for G is easy to remember, okay? Gastrin comes from G cell. What's their function? They put 3 functions here. You don't need to know all of them. All you need to know, gastrin stimulates the production of H+ in the parietal cell. Is that clear, folks? So gastrin stimulates the production of H+ in parietal cell. That's all you need to know. These are minor functions, not clinically important. So gastrin comes from G cell, produces H+. Why do you need hydrochloric acid here? It to digest the food. Does that make sense, folks? So when do you think you secrete? When there is a food in the stomach. How do you know when the food is in the stomach? Distension of the stomach stretches, folks, okay? That's the idea. And of course, there's a vagal nerve stimulation also there, okay? So gastrin comes from G cell that stimulate the parietal cell to produce H+. Is everybody clear, folks? Now, quickly, I want to go to the next page. Continue here. H+ comes from parietal cell. Who stimulates? Gastrin, histamine, and vagal nerve. 3 stimulation, okay? 3 stimulation. What's their function? Produce H+. When you produce H+, what happens? It becomes acidic pH. Stomach has one of the acidic pH. It's about 1.5. We all had a regurgitation in your life. I'm sure you tasted your acid in your mouth. It's very acidic, isn't it, folks? It's such an acidic, okay? So that's that here, folks, okay? Now, bottom line here to keep in mind, parietal cell gets 3 stimulations. It's very important. It gets 3 stimulation. One is histamine. Is it H2 or H1? One people go this way, which one? Is the H2 receptors. Okay. That goes there. And then we have a vagal stimulation, number 2. Number 3 is your gastrin. So 3 chemicals or structures can stimulate gastric acid. Is everybody clear, folks? Okay, that's important in the pharmacology, okay? 3 things can stimulate. Now, every time you stimulate a parietal cell, you don't just secrete H+, you also secrete a substance called intrinsic factor. That also comes from the parietal cell. You need intrinsic factor to reabsorb vitamin B12 at the terminal ileum, okay? I know they're talking about autoimmune disease. Keep it for tomorrow, pathology. We're not going to talk about that. So that's physiology here, folks. Is everybody clear? So that's about gastrin. You see, that's all you need to know about gastrin, folks. You know, I would, if I'm learning this, how I would do it, I would try to write it down on my own without looking to see if I understand. I would say G cell produces gastrin, and that gastrin goes to parietal cell and stimulate the production of H+. Does that make sense, folks? And it stimulates the production of H+, which causes low pH, acidic pH, right? Now, I would also write parietal cell get 3 stimulation. One is this, and 2 and 3. One is vagal nerve and histamine, you see. This is what we call writing things in a point form. It's the same thing what is in the book I'm writing like this. This will stay in your memory better than writing as a paragraph. See, that's your gastrin. That's all it is, folks. Is everybody clear? Okay. Now, let's go to the next one. Talking about somatostatin. I always tell our negative Nancy, it's an inhibitory hormones, right? What does that mean? Somatostatin, look at this. They never stimulate anything. They inhibits everything. So you don't have to really memorize. Anything they ask question, it negative, inhibits it. It inhibits it. Only thing you should know, somatostatin comes from D cells, okay? It comes from the cells in the antrum. I want you to write this down. This is not right. We want to say antrum. If you don't write this down, tomorrow you will have a hard time when I do gastritis. Okay, it's important. Somatostatin produce majority actually in the antrum of the stomach, because D cells are located in the antrum, folks, okay? So that's important tomorrow, all right? So that's somatostatin. The most important, if you ask me, what's that one thing in the entire page that's important? That's your cholecystokinin. If you don't know cholecystokinin, none of the gallbladder disease or your gallstone, anything will make sense, folks. Look at the word cholecystokinin, right? If I were to break this down, chole mean bile. It's stored in the gallbladder, and kinin mean move. So cholecystokinin is the hormone that helps to move. Now, without looking at the book, you kind of tell me, if you want to bring bile to the GI tract, what are the 2 functions you need to do? You need to contract the gallbladder. If you contract, bile will come out, isn't it, folks? What else do you need to know? You have to open up the sphincter of Oddi, isn't it? Look at the function here. Increase gallbladder contraction, relaxes the sphincter of Oddi so it can open. That's all you need to know. Those are the 2 functions of cholecystokinin. Cholecystokinin, contract the gallbladder, open up the sphincter so the bile can come into GI tract. That's all you need to know. It comes from eye cells of the duodenum and jejunum. And when do you need bile? We talked about it. Fat food, when we eat fatty food. Why did they put amino acids? Why did they put amino acids? Let's see here. What amino acids stimulate cholecystokinin? If you guys don't answer, you're going to write the page 74 again today. Ketogenic amino acids. Why ketogenic amino acids? Ketogenic amino acids are considered fat, isn't it, folks? What are the ketogenic amino acids? I think, Mallika, I heard it right. Type it up. Leucin, isoleucin, those things. All right. What's the name of the disease? The ketogenic amino acids was the answer. You give that as a treatment. Type it up. Don't say it. The ketogenic amino acids is the treatment for that particular disease. I'll give you my cell phone number. You guys gonna zail me $20 whoever get this question wrong, because we talked about this disease so many times. Well, I'm gonna tell Cindy, everybody's credit card charge extra $20 on the file. Okay, what's the disease? It's pyruvate dehydrogenase deficiency. Okay, Arsalan, you had a heart attack almost. All right, it's pyruvate dehydrogenase. Why? When people have a pyruvate dehydrogenase deficiency, we want more ketogenic. We do not want glucogenic, right? We don't want any more pyruvate. We want more acetyl-CoA. Good job. All right, I'm seeing some other diseases. I'm pretending like I didn't see it, okay? So that's that. That's cholecystokinin, folks, okay? Very important. So that's a cholecystokinin that does two of those. You see, when you know, it makes better sense, isn't it? You don't have to memorize cholecystokinin, it's just the function. Now, this is another important one, folks. Secretin. Secretin, S from S cells, make it easier. What it does, secretin increases bicarbonate secretion. And I want you to remember this, decreased gastric acid secretions. So in my drawing, actually, I could write this here. Secretin inhibits gastrin and stimulates bicarb. In another word, you could tell all secretin wants to do increase the pH, not decrease. It wants alkaline pH. Is that clear, folks? Secretin inhibits gastrin. Secretin inhibits gastrin. If you don't know that, we cannot learn Zollinger-Ellison syndrome, because they're going to do something called secretin test. We need to know what it is. Okay, secretin inhibit gastrin and stimulate bicarb, which means we are increasing the pH, alkaline pH. Is everybody clear, folks? Okay, so that comes there. When do you secrete secretin? Whenever there is an increased acidity, that's all you need to know. Whenever there is an acidity environment, you have more secretin. So you should pray if you have a duodenal ulcer, you should have more secretin, so it could be more alkaline. Is that clear, folks? All right, so that's that. So that's secretin. Are we all clear? These are the most important hormones. Now, look at this one, glucose-dependent insulinotropic peptide. That's a hormone. We did talk about it. When did we talk about it? When a human received oral glucose versus IV glucose, we said oral glucose person responds better insulin secretion is because of this hormone. Is that clear, folks? We covered where? In endocrine, right? So it's the same thing repeating second time, okay? So to recap, whenever we take oral glucose versus IV glucose, person who took orally will have better insulin response is because of this hormone only comes when you take it orally. Is that clear, folks? All right. Now next, Mortallin. What does Mortallin do? It's basically increase the bowel movement, okay? It increases bowel movement, folks, that's all. It increases. So there are medication, right? If you take medication that's Mortallin, increases the Mortallin. If it increases too much, what happens? Diarrhea. If you decrease too much, constipation. Is everybody clear, folks? Now you're going to learn something interesting. What's the side effect of erythromycin antibiotic? Don't look at the book, think. What's the side effect of erythromycin? Diarrhea. People who take erythromycin, they will have a diarrhea. Why? Erythromycin considered Mortallin receptor agonist. Even though they are antibiotic, when they take, they will have a diarrhea. Is that clear, folks? You see that? That's erythromycin. So we could use erythromycin not only for infection, also people who has hard time to move the bowel. Does that make sense, folks?
Why would diarrhea be increased in a fasting state?
Basically, what happened when you are fasting, your body tried to move because there's nothing in the intestine lumen, so they normally increases. That's why when you don't eat for a long time, you hear sounds in the belly, isn't it? It's just a fact. Whenever you are low glucose, it increases it. It's a physiology reaction that happens. Yeah. So that's mortallin, folks. Next, VIP, vasoactive intestinal polypeptide. What that does usually increase, or it opens up all the sphincter in the GI tract and bring in more water and electrolytes. What does that mean? You are making the lumen more watery. So that means it can have more liquidity in the intestine, folks. But when you have too much, that's your VI POMA, you produce more diarrhea. That will be a very bad, deadly diarrhea, okay? Because you are bringing more fluid to the lumen and open up all the sphincter. You're opening up like ileocecal valve, anal sphincter. It's a tornado, non-stop after that, okay? So that's what happens with vasoactive intestinal polypeptide, folks, okay? So that's that. Nitric oxide. What does nitric oxide do? Anywhere there is a smooth muscle, it relaxes it. Okay, it relaxes, whether it's a blood vessel or it's a smooth muscle of the GI tract. I know they are talking about the disease achalasia, leave it alone. All we need to know, it relaxes, folks, okay? We talked about ghrelin and biochemistry. What does ghrelin do? It comes from stomach, make you feel hungry. Ghrelin makes you feel hungry. What's the opposite one? Leptin, okay? Leptin, all right. So that's this. Now, you see here, I only highlighted those. These are simple hormones, not immuno. You should know, but whatever I highlighted, you cannot miss it. Continuing here, folks. Pepsin. This is super important to understand diseases. Pepsin comes from chief cells of the stomach. Okay, they come from chief cells of the stomach. But when they are produced as pepsinogen. That's very important, you pay attention. Every time we release pepsin, it comes in the form of pepsinogen, but then is converted to pepsin. Pepsinogen become pepsin. Who converts that? Your acid in the stomach. In another word, for you to convert pepsinogen to pepsin, you need parietal cell. Agree? Okay. Why do you need pepsin? Digest protein. It digests protein. So we could reabsorb all the protein. When do you stimulate? Vagal stimulation and local acid. But the most important thing, folks, if you eat a lot of protein, let's say you are drinking protein shake, eating a lot of protein, and you are taking omeprazole, what happens? Would you reabsorb any of the protein you took? So what does it tell you? When you take protein food intake, you should never take omeprazole. Why? Omeprazole inhibits the parietal cell to secrete H+. So when you take PPI, there is no acidity. Without acidity, can you convert pepsinogen to pepsin? No. So whatever protein you eat, it's all go out. Okay. So you can't wake up in the morning and take a PPI and then eat 200 grams of chicken. All comes in a fecal matter. Okay, so that's important. So you need acidity in order to convert pepsinogen to pepsin. This is again high yield. I will ask this tomorrow in a disease. There's a special disease where we lose protein. Okay, so that's
Can you
that.
please repeat it? Like, what
So
happens if
sure. What happens is, see, this is what, let me write this down here. Okay, so you have pepsinogen becomes pepsin. Who does the conversion? H+. Where do you get the H+ from? Parietal cell, right? So if a person take PPI, that's a proton pump inhibitor, they inhibit parietal cell to release the H+. Without that H+, pepsinogen will never become active, which means no protein digestion. Is that clear, folks? All right. That's released from the chief cell of the stomach. Let's check your knowledge now. You guys studied endocrine and everything, right? Where else did we come across the word chief cells? Type it up, don't say it. There's another chief cells in the body, secrete a different hormone. What is it? It shouldn't take this long. Where else did you come across chief cells? I'll give you a hint. It's part of endocrine. They also produce a hormone. That hormone is important to maintain calcium homeostasis. It's parathyroid hormone, folks. These are chief cells of the parathyroid gland that secretes parathyroid hormone, right? Did you guys use a different textbook? Right? In first aid, it's right there. Come on. Okay. That's also chief cells. Okay. That's pepsid, folks. Now the last one, bicarbonate. Now, when you look at a bicarbonate, we should be able to match it. Who stimulates the bicarbonate? Look at my drawing. Secretin, isn't it? See what secretin does? Secretin inhibit the acidity and stimulate bicarbonate. How does it do? Same thing. They inhibit gastrin, so they can bring in more bicarbonate. You could say it neutralizes the acid. It's secreted by secretin. Secretin is important, folks. I will write here. Secretin stimulate the production of bicarbonate. Where do you produce bicarbonate from? Some of them in duodenum, Brunner's gland. Remember that? Okay. That's a Brunner's gland that you secrete from, folks. It's important. Because there is a disease, not a disease, there's a treatment called Whipple's procedure, just to understand. Whipple's procedure is a surgery. They remove the most of the duodenum and pancreas, which means they don't have a Brunner's gland. They never produce bicarb after that. They have acidity and they get so many ulcers and stuff. Okay, that's why I was explaining duodenum is important for Brunner's gland. Is that clear, folks? All right. No. Most of the time when a student or somebody says, I don't understand this disease, or when you don't understand when you study, it is not your pathology knowledge, it's always the physiology. When you know your physiology and anatomy, everything will make sense, folks, okay? That's why when you guys jump into diseases, I pull you guys back. Diseases are interesting, but it won't make any sense when you don't know physiology and anatomy. Because when you know the normal, it's easy to identify the abnormal, okay? So secretin, you know this much secretin, you would understand every single aspect of Zollinger-Ellison syndrome, which we skipped. We need to do that. Why I skipped? Because without this part, I cannot make sense of that disease. Okay, so that's the key. That is your physiology of the GI tract. You see, not bad at all, right? So that's important, whatever we covered. Okay, now
I have a question. Sorry, so if we can go back to pepsin, peptinogen is present, and then it converts to pepsin. Pepsin is converted
so when they produce,
right?
When they produce as inactive form.
So what is produced first?
Pepsinogen is the one that produced, and then it's converted to pepsin by the presence of H+.
Because it started from pepsin, so I'm thinking maybe pepsin.
I know, but they just put the name because that's an active form, right? Think about it. Yeah. Angiotensinogen, fibrinogen, pepsinogen, trypsinogen, all of them are inactive. It has to be converted. Yeah. So that's what it is.
Thank you.
So that's this part. Go to this page, page 383. Let's continue with the bile. I'll come back to the other because we were talking about bile. It's easy to continue. Bile is composed of many things, but I just want you guys to highlight cholesterol. Without cholesterol, you cannot produce bile. And also remember, producing bile is one of the best way to eliminate cholesterol. Is that clear, folks? All right. Now the enzyme, that rate limiting step is 7-alpha hydroxylase. I don't think it's high yield, but you should know that word, okay? 7-alpha hydroxylase. Now, but let's talk about the functions of bile. Why do we need bile? Look at this. Digestion and absorption of lipid and fat-soluble vitamin. What are the fat-soluble vitamin, guys? A, D, E, K? Okay, A, D, E, K. Bilirubin and cholesterol excretion. Look at that. We just talked about it. And the last one, antimicrobial activity. So they also help to excrete, folks, okay? This is a disease again on the site. We will come back. We can't talk about Crohn's disease now. Okay. So that's a function of bile. So biles are produced in the liver, goes to the gallbladder, stored, and whenever you need, they secrete. Okay. Now, this page, very important. Bilirubin metabolism. We all have red blood cells. What's the half-life of red blood cells? 120 days, right? 120 days is the half-life, which means after 120 days in the blood vessel, red blood cells are broken down. Who does that? Macrophage. They break the red blood cell and they take the heme from there. Because why? In respiratory, we studied red blood cell is formed by heme and protein, globin. Is that clear, folks? So they take the heme and we call that heme unconjugated bilirubin. So when the heme is in the blood, it's called unconjugated. Then from there, they go to the liver. Liver has an important enzyme we call UDP glucuronidase transferase. What they do, they conjugate it. Once they conjugate, we call that direct bilirubin. Unconjugated, indirect, conjugated, direct. And from there, they go to the bile, right? Now, just to kind of keep, right? So I put this word, liver. This is blood. From the blood to the liver, liver to the GI tract. That's how it goes. Anytime you have a bilirubin in the blood to the liver, we call indirect. Because while they are in the blood, it's unconjugated. Indirect and unconjugated is the same. After the liver, it's direct or conjugated. Is everybody clear, folks? This is so important because we have quite a bit of diseases. Now, if I tell you, I break down red blood cell in the blood and I release a lot of bilirubin, what type of bilirubin would that be? Unconjugated or indirect, because it's before the liver. Does that make sense, folks? Any disease that brings bilirubin in the blood, it should be unconjugated. Any disease that brings the bilirubin after the liver, it should be conjugated. Does that make sense, folks? So if I tell you I have a patient with a total bilirubin 4.5, I'm making up this number, 4.5. In that, direct is 1.2. Where is the problem? Type it up. Is the problem in the blood or after the liver? I want to see if you can think. The patient have total bilirubin is 4.5. In that direct is 1.2. Where is the problem? That brings you a question, what's the normal bilirubin level, isn't it? So you have a chart, I sent it to you. But at least you could tell 4.5 is definitely high. So the problem is in where? In the blood. Why? If I have total 4.5 and if I subtract 1.2, what's the answer? 2.3, isn't it, folks? So 2.3 is your indirect, opposite. Whenever you have high, that means the problem is in there. So when you want to get an answer, you need both direct and indirect. If they give you total and one, you know the other one. Is that clear, folks? All right. So that's the idea. So then it comes from the liver. You could see it goes to the gut. In the gut, we have a normal flora.
I don't understand that. We get the indirect as 2.3 and then you compare it with the normal value of indirect and then come to a conclusion that
So the first thing you should do, the total, by looking at the total, you should know it's normal or not. 4.5 is high. Okay. Now in that, they're saying direct is 1.2, so I subtract, then you know the rest is indirect, because direct plus indirect is your total. That's how you get it. Okay. Now, once the bile goes to the gut, you have gut bacteria. That gut bacteria convert the bilirubin to urobilinogen. That's very important. In newborns, they don't have gut bacteria the first couple of days. How many people seen the fecal color of the newborn? It's very yellowish, isn't it? It's very pale. It's because when they are born, they do not have gut bacteria, so they will never get urobilinogen for a week. Is that clear, folks? That's why. Once urobilinogen comes, in that, 80% 80% of them excreted in feces as streptococcus. You need to know that. Streptococcus is the one that gives the color of the stool. Okay, that's 80%. 80% of the urobilinogen is excreted as streptococcus. The rest of the 20%, in that 20%, 90% goes back to the liver for recycling, and 10% goes to the kidney and excreted as urobilin, which gives the yellow color of the urine. That tells you yellow color of the urine is considered normal. I know sometimes we think yellow color means concentrated. Remember, folks, that has to be a yellow plus burning sensation. Is that clear, folks? Because we say colorless urine is considered normal. No, when the urine is colorless, that's diluted. Okay, so that's a yellow color is because of urobilin that gives that color. This is how bilirubin gets out of our body. Is everybody clear, folks? Now, when you know this pathway, then we have diseases that affect these things. Okay, there are diseases before the liver, and the diseases after the liver. We're going to talk about those things. But any questions in this section? No question. Okay. Now we're going to stop here because I think that concludes everything here. So your work today, take a lunch.